Hi, this is Nick Fogelson from Northwest Endometriosis and Pelvic Surgery in Portland, Oregon. I'm wearing a llama shirt that my wife bought me. See, it's crazy. I kind of have a day off. I dress a little casual, but I wanted to talk a little bit today about the concept of surgical fear and how it applies to endometriosis surgery. Someone just called me or sent me a message that they had really deeply invasive bowel endometriosis, and they showed me a picture of it, and indeed they had quite severe bowel endometriosis that, just based on the picture, to me looked like it required a segmental bowel resection to remove. And she had surgery. This was actually outside of the United States, and she had surgery, and the surgeon went in and kind of removed a little bit of endometriosis from the bowel superficially, but did not do a bowel resection. And she was told that it would be too dangerous and that it was a high-risk thing to do. This is what I call ineffective surgery because of surgical fear. Surgeons, we're all human beings, and when we're not very experienced with something, we all tend to be afraid, and it's just like any situation that you might be as a human being, inside or outside of surgery, that if you're in a situation that could potentially go wrong, but you're not very experienced with it, you'll be afraid and you won't move forward. And so sometimes we feel like we're doing the best thing for our patient by not proceeding with the more complex thing because we just haven't done it very much and we're really worried about bad things happening. The problem is that if you go in and do a surgery and then you don't do what is required, you will have done no benefit for your patient. And you will have in fact, you will have hurt your patient because you will have created new surgical incisions, you will have pain from surgery, you have potential risk from anesthesia, and in the end, that surgery will have no long-term benefit because you haven't actually done what is required. In the particular case that I was shown, the patient clearly required a bowel resection to address what is severely deep infiltrating endometriosis of the bowel. The problem is that the surgeon just isn't very experienced with that. And I can tell you this from my own personal experience. When I was just starting with endometriosis surgery, maybe a decade ago, I had a case where someone had very deep endometriosis of the rectum, invasive into the back of the vagina. And it was something that I was moderately experienced with. I was still a fellow in my sort of advanced surgical training, but I wasn't by no means deeply comfortable with doing that surgery as I am today. Today it doesn't strike any fear in me at all. I know how to do the surgery. I'm not concerned that I won't be able to do it well. I think based on my experience, I have a minimum likelihood of complication doing something like that. But at that point in my career, I was somewhat afraid. And at the same time, I was in an environment where there really wasn't someone better to do it. So I went ahead and did the surgery, and I got to a point in the surgery where I didn't entirely know how to proceed. And so I called one of my mentors, who was a very, very talented surgeon, but not an endometriosis surgeon per se. He really didn't spend a lot of time doing endometriosis surgery, although he was a brilliantly talented surgeon. And he came in, and he looked at the surgery, and he said, Nick, in order to do this surgery, we're going to have to take out the entire lower rectum and probably part of the upper vagina, and I'm not really sure that's worth it. And it was worth it, but we didn't do it. And we didn't do it because the person who I had called, who I thought was senior to me in that context, didn't really want to do the surgery. It was kind of a late in the day on a Friday. It was actually already in the evening because I'd gotten a bad OR start because I was a very relatively junior surgeon and I didn't have enough seniority to get a good OR time. And so it was late in the evening. We would have operated for another 4 hours, and in the end, I kind of allowed the influence of a more senior surgeon that said, hey, this wasn't really necessary to do, to influence me, even though in my heart I said, well, the whole point we're here in the operating room with this patient open is to do this surgery. And it seemed stupid to not do it. But I allowed sort of the surgical fear of the person I had called and sort of the indifference to influence me. And in the end, it led to a very unsatisfactory result, which is that we had done a surgery where I removed a lot of endometriosis, but I didn't do the one thing that she really needed, which was to do a big colon resection. And that was a very long time ago in my career. In my mind, it's almost a lifetime ago. But in that moment, the lack of experience and the lack of sort of support around me that would really support doing the right thing led me to do an ineffective surgery. And the patient got somewhat better, but not surprisingly, she continued to have problems. And this is what happens when people who are not very experienced with endometriosis try to do advanced endometriosis surgery. And I say it because I was that person at one point. At that time I did that surgery, I was that person. And I'm not now. Everyone that ever becomes really experienced at endometriosis surgery went through that phase at some point. So it's like a stumbling area in one's career. At the same time, unfortunately, there's patients that they may have operated on where they didn't do everything that needed to be done. What you find as you get through and you get further into a career in advanced endometriosis is you stop being afraid and you realize that these really complicated surgeries can be done, that we can fully remove endometriosis if we have the courage to do a bowel resection when it's necessary, if we have the courage to remove a piece of a ureter and reimplant a ureter. Another piece of procedure that a gynecologist thinks is horribly complicated and scary, and yet every single kidney transplant involves a ureteral reanastomosis because you have someone else's kidney being implanted in there, and obviously the ureter is not connected to the bladder when you start, and so you have to do a ureteral reanastomosis. It's a completely routine thing for a kidney transplant surgeon to do, and yet it seems like an absolutely radical thing for a gynecologist to do as part of endometriosis surgery. But once you do the first one, then you go, oh wow, that worked fine, the patient did well, and we fixed the problem. And then you do a few more, and then all of a sudden your fear is completely gone. And that's why if you have a really bad case of endometriosis, you have to see an experienced surgeon. Not just because they don't know how to do the surgery, that the inexperienced surgeon doesn't know how to do the surgery, but they may think they know how to do the surgery, but they haven't yet gotten past like the stumbling blocks in one's career where one just doesn't do what is right. Even though you know it's right, they just don't do it because they're not yet experienced enough to be past that fearful place. Now that being said, every surgeon gets through that place if they keep going in endometriosis surgery, and what one hopes is that when a surgeon is at that place in their career, they have the support people around them that will support them to do the right thing and help them in times when these surgeries are really difficult and they need that help, both technically and kind of emotionally. Like you need to have a team member across the table from you saying, yes, we can do this, we can succeed, we're not going to hurt the patient, and we're going to do something really good for the patient. And I just kind of wanted to say that because this person came to me and said she had this surgery that was ineffective. And I'm like, yeah, I bet the surgeon was afraid and they didn't want to do it. And I would just say that if you need complex endometriosis surgery, go to someone who's done it a lot. Ask them the question, how many bowel resections, if you need a bowel resection for endometriosis, how many bowel resections do you do a year? How have they gone? How have your bowel resections gone? Have you ever had any complications? And if they say, yeah, I've had a complication or two, that doesn't mean that they're not a good surgeon. If they've done hundreds of bowel resections, inevitably they will have had some complications. But then say, like, how do you handle these complications? Do you have a team around you that is going to allow you to handle complex situations that are slightly different? I have that. I have some great colorectal surgeons I work with. I have thoracic surgeons I work with. I have urologists that I work with. And I've been lucky that over time I've developed a great network of doctors that can help me do complex things. And even though I know how to do those things myself, because of privileging issues, often we involve this other surgeons in it. And I think that's just an important issue. So if you have something complicated, just make sure you see somebody that's really experienced, so that you can avoid a situation where they operate on you and then in the middle of surgery they bail and they just don't finish it. Doesn't mean they're bad doctors. It just means they haven't yet got past that place in their career where they don't do what's required. I've been in that place and I'm well past it now, which is why I do a lot of complex surgeries now. You just got to make sure that whoever you see is also in that place in their career where they're able to do those complex things and have success. Thanks for listening. And if you guys have questions, you can always send me an email. You can either send it directly to my Instagram. You can send it to Facebook at Nicholas Fogelson Physician. Or if you'd like to send me an email, you can as well through our website or nfogelson at nwendometriosis.com. Thanks for listening.